Hi, everybody. Dr. Calarco here with the PI Expert Secrets podcast. We know your time is valuable as physicians out there, and we want to thank you for spending your time with us today, where we're going to discuss all different types of pathology related to head trauma. We have a special guest, Dr. Treiber. Jared is a clinical psychologist who's licensed and is going to be walking us through, a lot of the different pathologies that we're going to see in clinic based upon, MVAs, slip and falls, and other PI cases specifically. So welcome to the show, Jared.
Hi, thanks for having me.
Of course. Can you give us a little background on you and how you started in this space?
Sure. So I originally had my degree in clinical psychology. And I was just kind of working in general populations, evaluations, traditional talk therapy. And then I kind of moved into a little bit of forensic psychology and neuropsychology. And I was seeing a lot of head injuries and um, just different things that were going on with people. And then I got offered this opportunity to learn about neurofeedback and how that works. And so I started doing some research, and it was really quite interesting on how the brain really controls more than just what we're seeing, more than just normal depression and anxiety. But when we have a head injury, like it's not just like, oh, there may be a bleed, there may be a bruise of some kind. No, it actually changes the electrical activity. And so I just really kept learning more about it. And then I ended up going back to school and learning a couple more, taking some classes on how the psychophysiology of it all works. And just kind of continued building from there. I went back to and got my postgraduate certificate in neuropsych from Ball State, became double board certified in neurofeedback and quantitative EEGs, and been practicing here at Chicago Mind Solutions since about 2014.
Got it. I think that's a good place to transition into Chicago Mind Solutions. It's a very unique clinical setting. I haven't seen anything like it, at least in the region, at least personally. Can you tell us a little bit about that before we dive into those specific traumas, head injuries, and then how we address those clinically?
Sure. So Chicago Mind Solutions has been around about a decade or so. I came in around 2014. So we have a select trained professionals who work in both traditional psychotherapy and neurofeedback, neuropsych evaluations, and we keep adding more and more to better help our patients. So we've added like an art therapist as well, different versions of neurofeedback, which I'm sure we'll talk about, just to kind of benefit our patients and anyone else who needs the help.
No, it makes a lot of sense. And I mean, as chiropractors, we see so much head trauma out there. And I know typically, I mean, you'll just send it off again. Maybe they don't have the resources in their specific region as a physician. I know many will just send it off to a neurologist, for diagnosis, for co-management. And I know for us specifically, finding you guys was, something that we really cherished, and we were really excited about what you guys could bring to each and every one of the patients who suffer head trauma. And I also think for us, it's extremely underdiagnosed, especially with MVAs. I know a lot of times, I don't know if it's due to lack of resources or just because the physicians out there aren't looking for it. But I can tell you from my personal experience, we just see it, very underdiagnosed when it comes to PI cases, which ultimately is going to hurt the patient, and it's going to really hurt the case value when that case settles, because you want to make sure you're accurately documenting all those injuries. Can you discuss how common head injuries are in general for motor vehicle accidents, and then we'll dive into these specific pathology that you guys treat?
Sure. I mean, it varies. So a lot of times with us, a mild TBI, you're not really going to see too much. It's like, unless there's a bleed, like the emergency room isn't going to see it on an MRI or a CT. So it's just basically some of the physical symptoms like nausea, dizziness, especially if they didn't have any loss of consciousness. A lot of times, oh yeah, just go home and rest. And usually within a week or two, people really start experiencing symptoms. And then they go back to their doctor and they're like, oh, probably concussion, just take it easy. And for 85% of the population, it heals on its own. It heals within, anywhere from 3 weeks to a few months. Um, but for 15% of the population, it can take many months or even years. I mean, we do see research has been showing that 10 years after a head injury, people can develop seizures out of nowhere. Um, so we're seeing a lot of these changes that occur that people didn't really realize what caused it all.
No, I think that's a really good place to start. Let's start with TBI and concussions then. So let's break into the two populations. So number one, you have the 85%. For the doctors out there, what should they be looking for, let's say initially during that initial exam, especially if they're seeing the patient within the first like week or two post accident? And then what should they look for in the
Mm.
long term in order to really recognize some of these symptoms?
Well, at the begin, excuse me.
Mhm.
So at the beginning, you want to kind of the basics, like any sensitivity to light or sound, um, any changes in personality, dizziness, vomiting, nausea, changes your personality. These are things, sleep patterns. These are kind of things that we want to notice. And even from a psychological perspective, did any trauma occur, like PTSD symptoms or increase in depression or anxiety? A lot of these things tend to occur. Now, even what we notice with military, um, when they come back from being deployed, they have to go back through a number of screenings. And a lot of times symptoms don't even pop up till 90 days or 120 days post deployment. So they're being screened again later on. And so those are things that you also got to take into consideration. Even after an incident, a few weeks later, they might be okay, but no one's really following up with them months later.
So I think that's a really great point. So for those doctors out there, they should be looking for those symptoms during that initial examination, and then at frequent points throughout the entire case, correct? Throughout
Yeah.
that treatment protocol, because while it might not show up initially, it's a really good idea to go through at, especially at the re-exams, but periodically during the treatment process to look for those indicators. And if they find those indicators, because again, 85% of the people, like you said, get better. Should they be sending them to you or somebody like you initially? Can you help facilitate quickening, the resolution of those symptoms, or should they hold off referring to somebody like you initially for those symptoms?
I mean, the sooner we can get them in, the better.
Right.
Uh, Usually want to wait like a good week or so after the incident, just so people can settle and kind of see where things are. And if they've had a previous neuropsych eval, then we have a good baseline, because otherwise we can reevaluate them and we can kind of see where their functioning is at that point in time, but we don't really know exactly where they were prior to the incident. So the sooner we can get them in and for a full evaluation, then we can really monitor progress and what their changes may be like in the future.
Yeah, excellent point. So, docs, you got to make sure you get them there initially. Anytime you're seeing any type of symptom, again, for those TBIs, for those concussions, which you're going to see super frequently, when it comes to the MBAs, to the slip and falls. This way, just like with X-rays, just like what we do, you have those initial exam findings, or again, that initial psych eval, so you can compare and contrast it to later to make sure that you know how well that patient is progressing, whether there's any exacerbations, etc. So when it comes to the TBIs, the concussions, can you walk us through some of the treatment modalities that you offer?
Sure. So depending on severity levels, um, we can offer different forms of neurofeedback, which is basically just helping to retrain the electrical activity um, to help reduce symptoms and even help the neurons kind of heal and start working the way they should be. So we can do traditional neurofeedback, which is kind of works a little bit on operant conditioning techniques, which will um, help with a lot of the psychological factors after a trauma. Uh, the lens, which is low energy neurofeedback, actually introduces a very low grade electromagnetic pulse to kind of help break up that dysregulation and kind of starts to stimulate those neurons to open up those pathways again to allow healing.
So for those who are not familiar with those two specific processes, could you break them down as far as exactly what that's going to look like when they refer their patients over to a clinic that
Sure.
specializes in treatment like yours?
Sure. So after a neuropsych evaluation and a brain map, or a QEEG, which is actually going to help localize exactly what's going on in the brain. So we can actually um, get a good picture of it. So it's just basically a traditional EEG, and we do a different quantitative analyses on it to help really localize it. And we could determine, usually if TBIs, for example, you may see an increase of delta waves or theta waves, and you can kind of see uh, where the incident was happening. And then with treatment wise, once we localize where it's coming from, with traditional neurofeedback, we would hook up the leads, and we usually have a patient perform a task. And when their brain is where we want it to be, they get rewarded. So, for example, if they come in after an incident and they're really very hypervigilant, a lot of anxiety, and we want to teach them to learn to relax, so we may put on a movie for them, something kind of light, something kind of relaxing, but the movie will only play when their brain is where we want it to be. So they get that immediate result knowing, hey, I can actually do this. And you're seeing those progress right then and there. With the lens, we're doing all the work. They come in and they're sitting there, we're measuring their brain, we're getting live readings, exactly what's going on. And we're going to stimulate those parts of the brain to kind of help facilitate the healing.
I think those were really, really good definitions, and I think that was extremely helpful for those out there who don't, follow this as closely as others. So thank you so much. Um, can we jump into anxiety and depression a little bit? I know, again, many of these head traumas are overlooked when it comes to auto accidents specifically, because that's our topic today, related to personal injury. But anxiety and depression,
Mhm.
often overlooked. Can you discuss how important it is for the doctors out there to keep an eye out for that during that initial examination and during the entire treatment process? And then when they find, those specific symptoms, how should they handle those?
So anxiety and depression are very common after an incident, especially after a motor vehicle incident. A lot of trauma, people become very hypervigilant. Um, and so a lot of times their stress levels increase, which changes their eating habits, their sleeping habits, um, weight changes, motivation, all that stuff can be impacted. And so if you're having those, it's going to impact your recovery as well. And so it's very important for doctors to continue to monitor those levels. I mean, I know even when I just go in for my normal physical every year, my PCP is like, yep, let's do your anxiety scales. Let's do it. So, because they know how important depression and anxiety is in terms of our overall health and our well-being. And that really can impact everything that's going on with us. So, just because you are being able to maybe fix the way the head is functioning, making sure the neurons are firing correctly, or you can set a broken bone, doesn't mean psychologically everything is fine. The best analogy is like you can be like a duck on the pond. On the surface, everything looks calm. Underneath, those feet are going a mile a minute. And a lot of times it's hard for people to talk about what they're really experiencing. Um, and those are things that you really need to keep an eye on.
No, absolutely. And again, I hate to keep saying it, but it's so often overlooked, and it plays a huge role. I mean, we know what kind of a role it plays. Obviously, not only in their patient's life and their ADLs and et cetera, but how it has an effect on the treatment. I mean, from our point of view, uh, it definitely puts the patient at a disadvantage. The more of those complicating factors that they're dealing with. When somebody has anxiety and depression, what are the specific modalities that you would offer in order to rectify that situation?
So, we offer a couple. We offer traditional talk therapy or art therapy, and in between those, you got CBT, which is very helpful. Mindfulness, sometimes some psychodynamic work, depending on what's going on with the individual. Well, some behavioral therapy, some neurofeedback, all combined can really be effective. Now, if things are really, really severe, sometimes medication is warranted, like a little anti-anxiety medication. It's helpful to kind of help move forward. But we try to work, other approaches besides medication so that the individual can actually really learn to overcome what's going on and how to manage it.
Yeah, no, absolutely. And like again, we don't have time as chiropractors or primary care physicians a lot of times to spend time with that patient to work through those things. We can discuss nutrition, we can discuss
Mm.
exercise and how that's going to have an effect on neurotransmitters, etc. But again, I think a comprehensive approach like that makes a lot of sense. How do you know what area, whether it's art therapy, whether it's talk therapy, etc. How do you know what that the pie looks like, the treatment pie, when it is every different for every patient based on their needs? How do you guys figure that out specifically?
Every patient's a little bit different. So when you come in, we do an intake, talk to them. What's going on? What are your strengths? What are your weaknesses? What type of things do you like? Because if a person is really reserved, really like tight, like after, especially after an incident, like they don't want to talk about things. So sometimes you need to find a way to help them open up and relax. So sometimes having them do an art project with you or something along those lines, people can just kind of relax because they forget about everything else that's around them. And
Right.
then
Yeah.
it's more free to
Focus rather than
talk.
head. Yeah, no, that's fantastic.
And then you kind of just start slowly adjusting and you adjust your modalities to the need of the patient.
And I know it's a hard question to answer because there's no specific answer to this, but generally, how many treatment times? It's going to clearly depend on the severity, just like for us. But do
Mhm.
you have like kind of on a bell curve, where the averages would be if you had to say?
Sure. So a lot of the research has shown that it takes at least 20 sessions for long lasting effects to really start to go on. You can start seeing positive treatments within the first handful of sessions, but to keep it going and lasting, it's going to take several months.
No, that makes complete sense. PTSD is something that we have been seeing a lot of.
Mhm.
Really, like, and it's one of these things that goes in waves. And is it because the patient's presenting with it, or is it because we're actually looking for it and finding it? And that's something that we think about pretty frequently. And PTSD, post motor vehicle accident, people not wanting to get back in the car, people having a fear of being the driver, even being the passenger in a lot of cases. We're seeing that very frequently with a lot of our cases related to the MVAs. Are you having that
Mhm.
same experience? Have you had that same experience for PI cases? And then how would you treat PTSD? I'm assuming it's a similar way to the anxiety and depression, correct?
Correct. So we've actually had an influx of PTSD patients recently,
Okay.
and we've been doing it for several years. But yeah, like all you said, people are afraid to get in the car, to drive, even be a passenger. We've had patients who won't even leave their house anymore.
Right.
So we started doing teletherapy just to kind of break that up as well. Um, and it's a lot of behavioral. It's a lot of exposure work to get them over some of these things. It's talk about the reality of things. Let's take baby steps to get through it and kind of work. So the traditional talk therapy, behavioral therapy is really effective and eventually leading them into the neurofeedback, which also teaches them to be able to relax their body and their brain so that they can see that they are in more control. Because a lot of times after an incident, car accident or MVA, it's a loss of control,
Right.
especially if they hit. And so their big thing is like, I can't control what the other people are going to do. And so it's just kind of working with that. So it's a lot of times it's that big loss of control that they have, and it's teaching them that it's okay, but maybe we can help you to get that control back.
Yeah, that's such a huge component. It's such a huge component. And you can see, when people are actually taking proactive steps from visit to visit, oftentimes you'll start to see them get that sense of control back. Obviously we can't control all the variables, but I think they feel better, as they start to heal, body and mind from, again, that comprehensive approach to care. We're working on the spinal column, we're working on the musculature, we're working on alignment, we're working on, firing patterns. And of course, all that proprioception and stuff does have an impact on the brain and on the mind. But at the same time, like you do need those specific treatments, and that's where the co-management just is so important. And again, I sound like a broken record, but often overlooked. And the reason I keep saying that is because when we go through these files, when we go through these cases, we'll see the same thing. And not only is it hurting the patient's long-term outcome, but again, I mean, if you are an expert in personal injury, the attorneys and the patient both want to see that you're fulfilling your obligation and making sure that you're doing everything you can to not only get them better, but also to document those injuries. And going at it alone, I think, especially as a chiropractor, sometimes when you're dealing with, again, the anxiety, the depression, the PTSD, the concussions, the TBIs, is just not the best way to proceed for the vast majority of those cases. Again, I think we can do a lot, but I don't think it's a one size fits all. I think it's definitely going to be a comprehensive approach. And that's, I feel like, the best part of medicine, right, is collaborating with those other specialists. You have a niche, they have a niche, and then you guys come together for the best outcomes. I wanted to get into migraines in relation to head injuries. Could you discuss that a little bit? Maybe your knowledge on how that begins and then what to do about it.
So migraines are always an interesting topic. So
Yeah.
we do get a lot of patients who come in with migraines.
Right.
Um, and the thing is about it is, I mean, there are many different types of headaches and migraines, and it's trying to understand what's coming from. So a lot of patients will talk about, oh, I have this pressure on the side of my head and it's horrible. And a lot of times we go, okay, well, that's usually tension and stress. I'm like, do you feel it from your shoulders all the way through your neck? And they're like, yeah. So it's kind of first identifying what it is. And then once we tell them, like, hey, a lot of times it's not the brain. Like the brain doesn't have the pain receptors. It's the constriction of the blood vessels. So it's really kind of working on teaching them how to relax. And we get a lot of patients from different neurologists who, yeah, I've tried these meds, I tried those meds, and they weren't working. And so, like, what else can we do? So we introduce some meditation, mindfulness, neuro, all those things combined. It really seems to be it helps it. So we do get a lot of patients with migraines, and they'll come in every day or every week, and they'll be like, "Oh, I was at an 8 or a 9 out of 10. Like I couldn't get out of bed." And after several weeks, you start hearing them like, hey, this week was only a 6. And then slowly we're seeing them like, I'm functioning. I have a patient a few years back who had several concussions, severe migraines, dizzy, couldn't even focus in school or anything. And one day she sent her mom a text message. She's like, I don't know what to do. I don't have a headache anymore. Like it was the first time in years. And both of them just started bawling. And those are incredible feelings.
Yeah, I mean, it affects your everyday life. There's no way you're, your best self when you're trying to have, you have this split screen almost in your mind, and the other half of it's trying to deal with, managing that pain, and the other half is trying to be present, in those outside
Mm-hmm.
activities. It's got to be extremely difficult, and I think stories like that just highlight, the importance of what you do and what you bring to each patient. And, the fact that you're comprehensive, and the physicians that you're co-managing cases with, should be comprehensive. They should be going through that treatment algorithm, going through systematically and see what works and what doesn't, making sure you're trying to take the least invasive steps as possible, and then working up, to maybe the more aggressive treatment modalities. I wanted to go through to kind of wrap things up and just discuss kind of what
Mm-hmm.
patient questions you commonly hear, when it comes to treatment, services, et cetera, even pathology. So neurofeedback, do patients find that uncomfortable at all?
No. I mean, sometimes like for their initial brain map, the QEEG, because they have to wear like a full electrode cap.
Right.
And it's not uncomfortable. It's almost like a swimming cap. Then we have to put the electrode gel in it. So usually that's the big thing. Like, oh my God, I got all this gel in my hair.
You're messing
That's
up
the
your
biggest
style.
thing. Yeah. It's like, I'm sorry. But we do really make it nice. We like these nice warm towels after we try to clean them up. So we try to make it a nice experience. But after that, it's nothing. It's just a few electrodes here or there. They get a little paste on them. But it's really not uncomfortable at all. And a lot of people ask us like, well, there's side effects.
That's where I was going
So
next. That's exactly where I was going next.
yeah. So traditionally there aren't any side effects. I mean, if we push it too soon, just like in any physical activity, like at the gym or something, if you're lifting too much weights, you're going to be really sore the next day. So we try to minimize that by working very slowly and working our way up to those levels. Um, if we go too much too soon, they may get a little headache. Sometimes it goes away, maybe a little Tylenol. Um, Other times they may get really, really tired and just want to go home and crash. Or other times they get this feeling like they're a puppy and want to run around all day. But those are the biggest side effects that you may experience. And we're pretty good at trying to minimize those.
No, that makes sense. I have a question for you too. When you go, so let's say we're co-managing a patient together,
Mhm.
you know, and not for everybody, but often somebody starts to feel better. They forgot they were an 8 out of 9. Now they're a 4 or 3. They kind of fall off a little bit. They maybe don't do the homework they're supposed to, or, again, keep up with things, maybe even appointments sometimes. Have you
Mhm.
found that to be the case for you as well? Number one. And then number two, how can, again, a chiropractor like me that's co-managing a case with you, how can we help support a patient that is actually involved in treatment, for all the conditions that we discussed previously?
I mean, it's just, you got to keep motivating them to keep going. It's like, great. I mean, you were at an 8 or a 9, and now you're down at a 3 or 4, which is great. It's a huge change, but there's still that potential for more. I always refer to them more like, say you got sick and you went to your PCP and they gave you an antibiotic for 10 days. Even though you might feel better after 7, you still need to take the rest of the 3 to really knock out everything. So we always tell them like, we'll definitely get to the point where we're tapering you off, and we have a plan for you because we want you to stay healthy and be the best person that you can be in the long run. But it is, it is in the end, it's up to the patient. All we can do is support them as much as we can, and we just try to encourage and motivate them to be the best they can.
Yeah, no, and we find the same thing, and I think the words of again, ultimately up to the patient, but reminding them of where they are, where they were,
Mhm.
and how to progress. And also that they could revert back again if they're not doing the things they should be doing. I think it's
Yep.
extremely important. So that was valuable. I think this brought a ton of value to the doctors out there. I want to thank you for your time, for everything that you do. With the patients out there. Again, this is something that I think is overlooked many times by doctors, but I also think it's becoming more in the mainstream, more people are becoming more aware, especially of PTSD, et cetera. So do you have any last words for the doctors out there when it comes to these conditions, what to look for, et cetera?
It's just really, really important to be there for your patients. Like follow up. Like it's not just a week after or 2 weeks after an accident. Um, it's staying with them. Like, hey, I'm gonna check back in a month. I'm gonna check back in 2 months. Like, what's going on? Like, hey, do they have a spouse? Do they have kids? Like, let me ask them. Are you guys noticing anything? Because sometimes patients don't notice everything. So sometimes it's important to get a perspective of those close to them. Be
Yes.
like, hey, how are they eating? Are they sleeping? What's going on? And that is when it's like, hey, maybe you should go and get this with a professional. Let's go get you screened. Let's get you an evaluation. Let's kind of see where you're at. I think it's really important to keep that going rather than like, oh, you're fine, or go home and get some rest. Sometimes these things take a few months to develop, and that's really is going to be key to recovery.
Yeah, again, be aware, right? Like don't, take things for granted. Don't just assume. Be aware, be detailed, be focused, in everything you do. Because again, you could overlook something like that can have major ramifications later on. So I'm really
Mhm.
glad that we ended on that point. I want to thank you so much for your time, Dr. Treiber.